I think now we'll go to Dr. KB's 10 minutes. So, what do we do when we have post-operative residual astigmatism? I think Dr. KV Satyamurthy sir is going to talk to us about that. Sir, over to you.
Yeah, good afternoon. At the outset, I would like to thank Dr. Deepak Megur for giving me this opportunity to be a part of this program. I think most of the difficulties have been discussed already. I don't know if I was not here. Anyway, I'll just go through. And you all know, there can be refractive surprises even with toric events also, maybe because of misalignment and other things. There is usually it can arise. There are various ways you can do it, but the common errors are that either pre-op measurement errors, or if the marking of the reference marking or axis marking is incorrect, or the incorrect placement of the lens, and failure to take into account the impact of surgically induced astigmatism. There are other reasons also which are not that common. So now let us go through certain examples to highlight these things. So, case a patient who 60-year-old female with a grade 2 sclerosis. It was not a difficult case, but her corneal astigmatism was more, two diopters at 150 degrees. So, lens was chosen for T5, toric lens was implanted, and surgery was uneventful, but post-operatively patient accepted -4 diopter cylinder at the same axis. That means we have added another two diopters to the existing thing. Uh, because of the wrong entry. So this is quite common actually, isn't it? So best thing would be to before surgery just look into the chart. See, many of us may not have time to do everything by ourselves. Your optometrist can do mistakes, so best thing would be to go through the charts. So that is a cause. And then another case where it was a simple cataract and surgery was uneventful, and the toric lens was implanted, but post-operatively patient accepted again cylinder. With correction, it was coming to again. This was because of wrong alignment of the axis. So it could be because of incorrect reference marking or in the post-op IOL rotation. So we speak so much about rotational stability, which may not be there with most of the other lenses. So we all know that 1 degree of rotation then results in 3.3% of the cylindrical power loss, and 30-degree rotation it becomes like a spherical lens. So axis rotation, how it can be done in various ways. How much to rotate after implantation of the lens, how much to rotate. So and there are various ways again. iTrace comes to help. This is what I use regularly. So here as you see, the reference markings are not equal. They are not at 0 and 180 degrees. One is at different point, other is at 170 degrees. So Zaldivar caliper helps us. There's an option where how much you should rotate so that you get the desirable axis. Otherwise, so here, for example, this particular case, patient required a 2.8 diopters of cylinder astigmatism, and then after rotation of about 30 degrees, it came down to almost zero point 0.4. Then we have online calculators like astigmatismfix.com. There are so many other online calculators which tell us how much we should rotate. And the another question is how early you should rotate the thing. How, see, before the fibrosis sets in. Usually it's said 2 weeks, 1 to 2 weeks, but some people say 4 weeks. So again, suppose patient comes to you at the after 6 months, still we can go ahead and do it. Only thing is you will have to uh, separate the lens from the fibrous capsule and then rotate it, and so take all the precautions like that. Another patient, a female, like just now we discussed about pterygium surgery. She had nasal pterygium which was recurrent, and so first pterygium surgery was done, and then later on patient insisted that she wanted multifocal lens. So toric multifocal lens was implanted in that case, and to my surprise, the astigmatism went on increasing, and it stabilized at the say 16 weeks even after surgery. Yeah, I mean, so it was around 4.5 diopters, and then every time she used to come and then occupy the chair for a longer period. And so the main problem here is like what we discussed. Once you do pterygium surgery, all the cases need not follow the same pattern. So one will have to wait for at least the cornea to remain stable. So one simple way is your chatometry value. Not everybody will have access to topography. Otherwise, best thing would be to have a topographic stabilization. So once you do that, then you assess the thing and then go ahead with the surgery. So not before that. Another case where a toric lens was implanted of about 3.75 diameter and a diameter cylinder. It was implanted at 32 degrees because the chart also showed the same thing, but patient required the same minus 3.5 diopter cylinder with additional sphere, and then the vision was not good, so patient was not happy with the thing, and again went back and checked the axis was corneal astigmatism was correct, the corneal measurements were correct, the topography was normal, and then so what went wrong was so after rotating the lens by about 120 degrees, patient started accepting because the pre-op astigmatism was the 3 point pre-rotation astigmatism was the 3.5 diopters at 30 degrees. So rotating to 120 degrees, patient was happy with the zero point 0.5 cylinder, and I was able to read up to 612 because of amblyopia. So here the main problem was probably since all other factors were all right, so it was probably a faulty lens. And in fact, if you go through the net, there are a lot of articles on this. Your lens can also be at fault. So we need not blame us only, ourselves only. Another case where a patient uh, underwent surgery in both way because he had diminution of vision, and then he was wearing contact lenses for a longer period of more than 30 years. He was a diabetic, retina was normal, and it was a simple case, so surgery went on very well. Pre-op refraction was somewhat like this. Since left eye didn't have much of astigmatism, only uh, paired opposite clear corneal incisions were made, and then right eye toric lens was implanted after taking into account all these things. But post-operatively, patient had this much of astigmatism, which he didn't accept. He wanted something better. That is again due to maybe because of aggressive counseling that we do. So probably what was ignored was after surgery, topography was done, and this was the thing. It was a case of an aborted keratoconus. Patient didn't realize. Throughout, he was wearing contact lenses, and he had reasonably good vision. So bilaterally, it was like that. And then, if you just look at the higher order aberrations that were present, it was much more. Say around coma was around 1.6 in one eye, and the other eye was also more. So higher order aberrations were more, and this was explained to the patient that your cornea is not healthy and it's better not to touch it now because it can lead to other problems also. So finally, the patient has settled down with the existing correction. So, the take home message here is first we should take along with, I mean, normally we take, but any patient wearing, say, rigid contact lenses for a longer period and getting good correction only with the contact lenses, then that should we should start thinking in these terms. And such selected cases, it is better always to do corneal topography pre-op so that counseling would be better. Otherwise, you'll land in trouble and your chair time will increase otherwise. Another case where LASIK was done about 20 years back, and now probably future this is going to be the thing. We also always ask the patient. So patient had it was a simple cataract, and after thorough counseling, he underwent phacoemulsification with the toric multifocal lenses or the trifocal lens now. And then post-op result was like this, somewhat like this, but patient was not happy because he had paid so much of money. And then the topography showed higher the corneal wavefront aberration showed higher order aberrations of almost 1.5 of coma and so like this. So and spherical aberration was more. So patient was not happy. Initially thought of doing IOL exchange for this patient, but after looking at the higher order aberrations, we thought it's better to treat the cornea rather than doing the IOL exchange. After doing topo-guided PRK, patient is now 6 9 and 6 both eyes, and happy, reasonably happy. So it is always better to rule out the higher order aberrations. Always look at the cornea, because that is what you are going to correct. And corneal astigmatism, it is not just the axis which is going to tell. So patient having higher order aberrations, and then treat the cornea prior to surgery, or probably this will help us to do proper thorough counseling. They should not expect very good results with a bad cornea like that. So it need not be a picture perfect result all the time. Toric IOLs can be, I mean, the results can be elusive, similar to post-op spherical error surprise. Toric IOLs can also throw a surprise for various reasons, which we need to address. Thank you very much for your patient listening.
Thank you, sir, for sharing a complex series of cases. I think once we begin with simpler cases, we end up having all these situations. And thank you for sharing your experience. What would be the right time and the technique to rotate the lens when you have noticed that there is
Yeah,
the axis is wrong?
right.
You flip the axis, you put in wrong
No,
axis.
that's what. So I prefer to do it as early as possible before the fibrosis
See, I
sets
think
in,
that's an
maybe about
important message.
1 to 2 weeks.
So
But
yeah, you want to see the refraction stabilizer say 1 week or two. If it doesn't, then I think you should not wait further.
correct, that's
Go
right.
in and
Wait
then
for the,
do it.
yes,
It is not very difficult to rotate the lens at all. Just don't wait on it. Sit on the patient. An unhappy patient is going to go to the next doctor and he will point out the mistake. So just maybe 2 weeks would be ideal, not more than that. That should be easier to rotate even these hydrophobic lenses. Any
Also, sometimes we think it's a very small amount of rotation, it won't matter, but actually, even small rotation matters a lot in toric lens, especially if you're dealing with a higher cylinder.
yes,
If you rotate 30 degrees, the entire effect of the toricity is
it's
gone.
gone.
So the one interesting observation that I've had with this Zaldivers caliper, since you mentioned that on the eye trace, is that even if you have a happy patient and zero refractive outcome post-operatively, you ask them to sit before the eye trace and take the Zaldivers, it still shows you a rotation. So that's
correct.
one thing. So it perhaps is inclined towards indicating a post-operative IL rotation, which sometimes might not be necessary. I mean, it's just an observation. Obviously, why would you ask the patient to sit before the eye trace if the patient is happy? The other thing is the refractive outcome, if is like a neutralizing each other perspective, like a +2 with a -2, a +2 with a -4, they actually respond the best to IL rotation. So even if the patient does not accept it, if the autoref shows a +2 with a -4 cylinder, meaning neutralizing each other, the spherical equivalence becoming 0, they are the best candidates for an IL rotation. They behave the best post-rotation too.
Yeah, I think
Right.
whether I don't know whether it was mentioned. So there is a site
Yeah, it mentioned.
www.astigmatism.
It was mentioned.
Yeah. So I think that's the thing, that whatever you have, put that data, and it will tell you whether rotation will solve the problem or we have to explant and change. Yeah.
Any one question from the audience? Anybody wants to have a question from the audience? One question. 2 more minutes we have. Is a hand somewhere? Yes, yes. Okay, hand. Okay, sir. Boramani sir.
I just want to ask one simple question to all panelists. Forget about the surprise shown by Dr. Satyamurthy. How many of you are routinely get, or percentage wise, the moderate surprises, say only 0.5 diopters of astigmatism, is irrespective of or in spite of proper calculation, no errors, nothing, perfect surgery, no heating of the cornea also. But on an average, say, or no one is getting say 0.20, say 0.5 astigmatism
You mean to say after toric lenses?
after toric lenses.
I think
Yeah, very common.
point.
Very common.
Very
Very
negligible.
common.
Is it
We
very common?
target only that 0.5 only, sir. We don't target 0.
Okay.
Zero,
Because
zero.
many phaco surgeons, they are advocating toric for 0.5 also.
Yes.
That's why I'm asking.
0.5, if it is
Just
against the rule, then it amounts to almost 1 diopter of astigmatism. So for against the rule 0.5, we have to correct it.
no, for with the rule 0.5, it will not even show you a toric requirement, the calculator. The question here is, sir, even if the output is 0.5 and you're trying to correct a 0.5, a lot of times we face this question, does it need to be corrected at all? So the point here is, when you are giving glasses to the patient post-operatively, you are essentially correcting the lower order aberration some distant away from the nodal point. With the toric IL, you're correcting that lower order aberration very close to the optical center. It still gives a wow to the patient. even if it's 0.5. So the counseling has to be, if the patient is already wearing glasses and is happy with it, then I quote them my example. I have been using glasses for 42 years. I'll be very happy to shed with it, to do away with it. And if the patient is not wearing glasses and has a cylinder, it's even easier to counsel. You're not wearing glasses, you would perhaps not like to wear glasses even after you operated. So two ways of counseling, but they meet at the same point.
Sir, quickly, last point.
Yeah, I just wanted to emphasize that when you're doing a trifocal IOLs, and then the toricity becomes a very sensitive issue.
Yes, absolutely.
And therefore, even if you have 0.5 diopter of astigmatism required,
Not
it has
acceptable.
to be corrected.
Absolutely.
Because there are situations, if you feel that it was 0.5 and you have not done it in one eye, and then they don't have that good vision, if you correct it in the other eye, they would keep on telling you that
Very true.
this eye is not good.
Absolutely.
So in trifocals, toricity has to be removed.
Absolutely.
I think for toric, lack of money is the only true
can I add one thing?
contraindication.
I think we're running out of time, sir. I
Yeah.
think
Just 1 minute. I'm
yeah,
only.
sure,
I will
sure,
not
sure.
take more time.
Sure.
See this. If you really are looking at, I mean, point blank thing. I mean, it should be completely zero. Then probably you can go ahead with the PRK and do it. Probably with the laser vision correction can achieve good results in
Okay.
these cases.
Okay.
What about pediatric cases? Say the age group is between 13 to 15 and cylinder is more than 2.5.
Yeah,
Will
you should.
you plan for toricals
Yeah, of
for them?
course. I think, of course, we have. To
Most children have with the rule astigmatism, and it's going to go on reducing. Or so generally under correction. That's what I do. For
Usually mild undercorrection, because once they cross 40,
Mild undercorrection.
it's going to
yes.
have with against the rule astigmatism progression. So mild undercorrection. But anything which is more, no, you have to correct.
Save for the patients wherein it's difficult to take a proper biometry. If the patient has an nystagmus, for example, if it's not taking a proper biometry, then the equation changes.
Yes, a corneal incidence is an option, but the problem is they are not as predictable as the toric IOLs. So that is
The OCCIs?